Good morning. I'm Dharam Kumbhani. I'm an interventional cardiologist at UT Southwestern in Dallas. And I'm delighted to be here with Dr. Van Hoff, who is the principal investigator of the Celebrate trial. Do you mind introducing yourself for the audience?
Yeah, I'm Arnoud Willem. I'm the head of the Department of Interventional Cardiology at the Maastricht University Medical Center in Maastricht, and also in Zuiderland Hospital in Heerlen, and the principal investigator of the Celebrate trial.
So congratulations on this very important trial. So can you tell us a little bit about the patient population that you were looking to study in this trial?
Yeah, it's a patient population with presumed STEMI. So of course in the ambulance situation and outside the hospital, you have you're not 100% sure that it's a STEMI, but it's the same at the ER, you do not know. But we included presumed STEMI patients who had less than 4 hours of symptoms. And we had some in and exclusion criteria. Main exclusion criteria were the patients who had oral anticoagulation, who were resuscitated, or who had cardiogenic shock, and the patients who were on active bleeding, of course. We really focused on the patients who came in with less than 4 hours of symptoms, because we knew from previous studies that these patients have the best opportunity to improve patency by antiplatelet drugs. Yeah.
So you're studying the pre-hospital side of a STEMI presentation, and what was the drug that you were looking at, and what was unique about this agent?
Yeah, the drug Zelenfiban is a third generation GPI, which is really developed as a drug which can easily be administered in the pre-hospital phase. It needs a single subcutaneous injection in the forearm. And it's just this single administration is very easy for ambulance personnel to administer. It can be even given at the home of the patient. It can be given in the ambulance. It can be easily given at the ER. And it's a drug which specifically has a short half-life. So within 2 hours, there's less than 50% of platelet aggregation. So it's meant as a kind of bridge to oral P2Y12 blockers. Many of these patients receive agents like ticagrelor and prasugrel, but these agents become only effective after 1 or 2 hours. So in this first 1 or 2 hours, you want to have already high intensity platelet inhibition, and you do not want to have a high bleeding risk with continuation of your efficacy of, for example, this drug Zelenfiban, and that's why it was really designed as a potent drug, but not giving the higher bleeding risk. Yeah. So
there was a lot for this for the design to work through, where it had to be in the right window. The oral agents don't have enough time to be helpful. You were involved with other trials in this space. And then the IV agents like tirofiban, we've seen they are harder from administration standpoint, et cetera. So in addition to finding, so there were a lot of boxes that this drug had to check, and it sounds like you were able to find this with this particular agent.
Yeah, you really look for the so-called ideal drug, and of course there's no perfect drug, but you really this drug was really designed to be a better drug for pre-hospital treatment, because I really think this pre-hospital phase is under-recognized and underappreciated. We should really be able to give treatment, and for example in the PCI HELP trial, which was presented last year, we saw that heparin is also able to improve patency, and that's, I think, a good step forward. But in the end, heparin does not induce platelet inhibition, and you need, for your primary PCI procedure, you really need platelet inhibition. So on top of these agents, Zelenfiban showed to further increase patency in these patients. ending up with a 52% patency rate in the patients in the Zellenfiben group. So half of these patients had an open infarct-related vessel with often less symptoms and less ECG abnormalities the moment they came in the cath lab.
Yeah, that is outstanding. So, so it sounds like the drug did what you felt it would do from a mechanistic standpoint, given what you know about the mechanism of action. What are the clinical findings? What do you see?
Yeah, what we saw is the improvement in corrected TIMI frame count and initial TIMI flow, as just mentioned. And we also saw an improvement in ST resolution. We made a second 12-lead ECG the moment the patient came in the cath lab. And we compared the diagnostic ECG to the second ECG, and we saw a significant higher ST resolution in the Zellenfiben treated patients, showing that that these ECGs showed better, or not normalization, but showed better resolution as compared to the patients who came in with placebo. So these were really things which we expected, and because of this mechanism, we also expected that when you have an open infarct-related vessel, you end up with a smaller infarct size and less heart failure, and that's why we wanted to find out really in this trial whether Zellenfiben really results in an improvement in clinical outcome, not only patency, but really clinical outcome with regard to reduction in heart failure and infarct size. Yeah.
And so you observed at 30 days, you observed an improvement in your primary endpoint, which was a composite. And as you mentioned, it appears that the primary drivers of that were related to a reduction in infarct size.
Yeah, we also saw a strong trend in the reduction in heart failure, and these two parameters were really the drivers of the primary outcome. And we saw a significant reduction in acute stent thrombosis, but this was, of course, this occurred so infrequent that it did not increase or decrease a lot the odds ratio. But it was when we looked at the individual endpoint in a non-hierarchical analysis, we really saw a significant decrease in acute stent thrombosis. Yeah.
So, those are very important results. And, as with any antiplatelet agent, the yin and the yang is always a benefit in ischemia. What did you see on the bleeding side?
Yeah, we didn't see a significant increase in gusto major or life-threatening bleeding, but we saw an increase in minor or moderate gusto bleeding. And we expected this higher increase in minor or moderate bleeding, because I'm really sure that there's no free lunch for antiplatelet or antithrombotic agents. I feel more concerned the moment you do not have access or a little bit more bleeding, because then you want to know whether the drug is effective, yes or no. I always compare the outcome to the CURE trial, from which everybody was very enthusiastic about, and they forgot about the higher bleeding risk in the CURE patients. Yeah, in the clopidogrel treated patients. Yeah.
So it sounds like what you observed is you saw a reduction in ischemic endpoints. There was no increase in major bleeding, but there was perhaps an increase in mild to moderate bleeding at 30 days.
Yes.
So do you have longer term follow-up that is planned for these patients?
Yeah, of course we do not have 100% follow-up yet, but we do plan a 1-year follow-up in all these patients. Yeah.
To see if perhaps your reductions in infarct size and maybe risk of heart failure would translate.
Yeah, we really hope that they translate into an improved 1-year outcome as well. Yeah.
One last question from my side is, you've been a pioneer in this space, and this is a population that would seemingly be very hard to enroll in clinical trials, given the time sensitivity with which interventions are needed. How has your group, your team, managed to work on this aspect?
Yeah, I think I'm definitely a believer of the future of STEMI care is in the ambulance. because that's the way where the diagnosis can be made very quickly after they call 911 or 112. And with the use of artificial intelligence, even ambulance people can really have a good diagnosis of STEMI or occlusive myocardial infarction in the ambulance. Of course, it's a challenge to do trials like this. You really need dedicated people. But for example, the experience in our trial was that the people in the ambulance really were disappointed when the trial stopped, because they were really convinced that they did something well for the patient. And I think this is how we should go with STEMI care. We should organize ourselves in these STEMI networks. We should go out and find these people in the ambulance and motivate them to really diagnose the STEMI or occlusive MI patient properly and give the right drugs at the right time. Yeah.
On that note, we'll end. This is, a fascinating discussion with Dr. Van Hoff about the Celebrate trial, and, look forward to reading more about it.